Welcome to JACC This Week. I'm Harlan Krumholz, Editor-in-Chief of JACC, and this is our issue for August 26, 2025. This week's issue features compelling new science that answers important questions and sparks new ones. We start with a randomized trial comparing conduction system pacing with right ventricular pacing in atrioventricular block. And I'll explain why it complements another major trial, prog-CSP. We'll look at whether portable HEPA filtration can reduce blood pressure. And we'll revisit the flavor trial, now with long-term follow-up, connecting it back to its original New England Journal of Medicine publication in discussing what the new editorial calls the duality in PCI guidance. We also have a state-of-the-art review on the path from heart failure trial results to real-world implementation, a brief report on fine-tuning the definition of pre-heart failure, a leadership page on health equity, and a striking Amara Yad anatomical image. We're also including 2 reprinted case reports from JACC Case Reports. So let's begin with the original research. Conduction system pacing versus right ventricular pacing in AV block, the C-SPACE study. For decades, right ventricular pacing has been the standard for patients with AV block who require a pacemaker. It's effective and reliable, but it comes with a drawback. Chronic RV pacing can cause dysynchronous ventricular activation and, in some patients, pacing-induced cardiomyopathy, a measurable decline in LV function over time. Conduction system pacing, which includes His bundle pacing and left bundle branch area pacing, aims to maintain physiologic ventricular activation and avoid that dyssynchrony. Observational studies have suggested benefits, but robust randomized evidence has been limited. The C-PACE study, randomized controlled trial, enrolled 202 patients with AV block without an indication for CRT and assigned them 1-to-1 to RV septal pacing or conduction system pacing. After mean follow-up of just over 2 years, conduction system pacing was associated with a significantly lower rate of the composite endpoint: pacemaker-induced cardiomyopathy, CRT upgrade, heart failure hospitalization, or all-cause death. 7.17 versus 20.7 events per 100 person years, with a hazard ratio of 0.35 and a p-value of 0.001, less than 0.001 actually. But this benefit was mainly driven by a marked reduction in pacemaker-induced cardiomyopathy that had a hazard ratio of 0.31 with a p of 0.002, and virtually no CRT upgrades in the CSP group. Rates of heart failure hospitalization and all-cause mortality were lower, but did not reach statistical significance. Lead revision was more frequent in conduction system pacing. The authors conclude this RCT demonstrates the superiority of conduction system pacing over RV septal pacing in achieving improved clinical outcomes and supports CSP as an upfront pacing technique for patients with AV block. It's worth noting that the prog-CSP trial, presented around the same time that this article was accepted, it had been presented at the HRS meeting, also favored CSP over conventional pacing, but in a different population with a different primary outcome. Taken together, these trials strengthen the case for physiologic pacing as a default strategy for many patients with AV block, while also reminding us that conduction system pacing demands operator expertise and carries its own procedural considerations. Next paper, HEPA filtration and blood pressure, a pragmatic randomized crossover trial. We've known for years that air pollution, particularly fine particulate matter, is linked to cardiovascular events through mechanisms like inflammation, oxidative stress, and vascular dysfunction. Most studies focus on outdoor exposures, but indoor air quality is often worse and receives less attention. So we have a study that focused on indoor air pollution. Doug Brugge and colleagues conducted a pragmatic randomized crossover trial in older adults, alternating periods with and without portable HEPA air purifiers. This was actually a sham study. The design was quite nice. They found that during filtration periods, systolic blood pressure dropped by about 3 millimeters of mercury. Now, that may sound small, but actually that rivals the size of a reduction in several antihypertensive trials. So it's not really trivial. So this could translate into meaningful population level benefits in terms of reduced stroke and MI risk. As Newman, Rajagopal, and Brooke note in their editorial, breathing easier may not just be about comfort, it may be about cardiovascular intervention. This study is a reminder that prevention sometimes comes from unexpected places, and that something as simple as a plug-in purifier might make a measurable difference in cardiovascular health. I'm going to get into this study in a little more detail in a deep dive bonus content to this podcast in case you're interested. Next study, long-term outcomes after FFR versus IVUS-guided PCI, the flavor extended follow-up. FFR and IVUS are both widely used to guide PCI, but they answer different questions. FFR tells you about flow. It's more physiologic. IVUS provides anatomic detail about plaque burden, morphology, and stent deployment quality. The flavor trial published in the New England Journal of Medicine, the main article, reported that they had randomized over 1,600 patients with intermediate coronary stenosis to FFR or IVUS-guided PCI. At 2 years, FFR was non-inferior to IVUS for the composite of death, MI, or target vessel revascularization, and patients in the FFR group received fewer stents. This new paper by Yang and colleagues extends the follow-up to a median of 6.3 years. The key finding? Results are consistent. Event rates remained essentially identical, 8.1% for FFR versus 8.5% for IVUS. And procedural patterns persisted, with PCI rates of 44% for FFR versus 65% for IVUS. Jeremias, Volberg, and Ali note in their editorial, if the goal is to reduce procedural complexity and avoid unnecessary intervention without compromising outcomes, FFR may hold the advantage. IVUS may add nuance in plaque instability. They go on, and I thought this was worth quoting. If the goal is to reduce procedural complexity and avoid unnecessary PCI, FFR seems to be the optimal tool. However, if the aim is to reduce long-term events driven by plaque instability, IVUS may hold an advantage. If FFR reduces stent use and IVUS expands plaque coverage, could we harness the advantage of both technologies and have the best of both worlds? Combining FFR and IVUS could maximize safety and efficacy. Unfortunately, cost and complexity may preclude routine use of two separate adjunctive technologies. New tools that merge anatomic insight with physiologic precision may be the future of optimal PCI. Imaging-based physiology such as IVUS or OCT-derived FFR could offer a cost-effective hybrid strategy, confirm functional significance, plan PCI, identify lesions with adverse features, optimize stenting, and confirm physiologic success, all without needing two separate tools. And then I really like this line. In the end, flavor does not crown a winner. It exposes duality. So long-term head-to-head data like this are rare. The NEJM paper gave us confidence at 2 years. This follow-up reassures us that both strategies are safe and effective over the long haul, while highlighting an important discussion about combining or even merging these approaches in the future. In this issue, we have a state-of-the-art review by Sanjay Kaul, Evidentiary Landscape of Heart Failure Therapies. He takes a wide-angle look at how heart failure therapies move from positive clinical trial results to regulatory approval and then into guideline recommendations, and why this process is often slower and less straightforward than we'd like. He dissects the roles and sometimes misalignments between regulators who focus on safety and efficacy in controlled environments and guideline committees who weigh broader clinical applicability, cost, and health system priorities. The evidentiary standards also differ. Regulatory approval may rest on a single pivotal trial, while guidelines often require multiple confirmatory studies or meta-analyses. Kaul points out that delays in adoption aren't always about insufficient evidence. Sometimes they stem from inertia, resource constraints, and differing interpretations of the same data. His roadmap for improvement includes early engagement between trialists, regulators, and guideline developers, streamlined evidence appraisal frameworks so practice-changing results can move more quickly into recommendations, robust post-market surveillance, and I want to endorse this strongly, that's what we need, to confirm benefit-risk profiles in real-world populations, and proactive implementation strategies to ensure therapies reach patients promptly once recommended. The take-home? Aligning the evidentiary pipeline is not just about speed, it's about ensuring that the right treatments reach the right patients at the right time, with a process that's rigorous, transparent, and responsive. We also have a brief report, age-adjusted NT-proBNP cutoffs for pre-heart failure. Kai and colleagues evaluated whether age-adjusted NT-proBNP thresholds could improve diagnostic accuracy for pre-heart failure. In a large cohort, this approach improves specificity in older adults without sacrificing sensitivity, potentially reducing overdiagnosis and its consequences. There's a leadership page from the ACC, Health Equity and Cardiovascular Care. Chris Kramer and Melvin Eccles remind us that achieving health equity is not optional, it's a clinical imperative for better outcomes. They outline actionable strategies for narrowing disparities in cardiovascular care and outcomes. This happens to be a good pairing with the editor's page this week. The editor's page is an update to the JACC Report Card, one of excess cardiovascular mortality among Black Americans, 2000-2023. It's kind of unusual to do it this way. This editor's page presents new data rather than just commentary. And it does so because the topic's so important. It was released on Juneteenth, a date chosen for its symbolism, and it focuses on the persistent and profound disparities in cardiovascular mortality between Black and white Americans. In this editor's page, we updated something that we had published last year, and now we've analyzed the national data from 2000 all the way through 2023. The focus is on excess death and years of potential life lost, measures that quantify not just mortality rates, not just age-adjusted mortality rates, but the real scale of life years taken prematurely. In 2023, excess age-adjusted mortality rates and years of potential life lost among Black Americans largely returned to pre-pandemic levels. And in some areas, especially ischemic heart disease, there was incremental improvement. But the overall picture remains pretty sobering. For CVD overall, the excess mortality rate was 89.6 per 100,000 for women and 153.9 for men, translating to over 1 million years of potential life lost. Hypertension, cerebrovascular disease, and heart failure also contribute substantially to the gap. So despite some gains, the disparities remain large and are entrenched. The core question remains, why should a social construct, race, be such a powerful risk factor for cardiovascular death? We invest enormous resources into understanding other risk factors like cholesterol or blood pressure. We need that same level of urgency to understand and address the root causes of racial disparities. Take home, while there's been some progress since the pandemic peak, equity in cardiovascular outcomes remains far from realized. It's not just a matter of public health statistics. It's about fairness, justice, and the urgency of saving lives that are being lost too soon. The issue also has an Amar Yad issue, as we have in so many of our issues. This one has a stunning interior view of the septal aspect of the right atrium. And I have to thank Dr. Shiv Kumar for pulling all this together. It's really a blend of art and education. And to finish off the issue, we have 2 case reports reprinted from JACC case reports. TAVR and surgical valve for recurrence of failed bioprosthesis. This is really quite an interesting case. It really shows a lot of complexity and considerations in redo transcatheter valve cases. And secondly, contemporary management of severe carcinoid heart disease, where Guerin et al. Outlined a multidisciplinary management approach to a rare but high-impact condition. So what did we learn from this issue? Conduction system pacing preserves LV function and improves clinical outcomes compared to RV pacing and AV block, supported by C-SPACE, which we present here, and also PROG-CSP. Second, improving indoor air quality can modestly lower blood pressure, but really in a meaningful way, with potential population-level benefits. Third, FFR and IVUS both deliver excellent long-term PCI outcomes, but their strengths differ. And as the editorialists say, combining them could even be the next frontier. But in this issue, we show that out to a little more than 6 years, these still are just about the same with regard to their outcomes. Next, aligning the evidentiary pipeline for heart failure therapies can shorten the time from trial to patient impact. We ought to pay attention not just to what happens in the research, but how it translates all the way over to the bedside. And finally, achieving equity in cardiovascular care is both a moral obligation and clinical imperative, and the stats show we continue to lag. I hope you've enjoyed this episode of JACC This Week. Look forward to the next one. Until next time, stay curious.